Good evening. I'm psychiatrist Jay Fulver, live from Fort Wayne, Indiana. Welcome to Matters of the Mind. Now in its 27th year, Matters of the Mind is a live call-in program where you have the chance to choose the topic for discussion. So if you have any questions concerning mental health issues, give me a call in the Fort Wayne area by dialing 969-2720, or if you're calling anyplace else coast to coast, you may dial toll-free at 866-969-2720. Now on a fairly regular basis, we are broadcasting live every Monday night from our spectacular PBS Fort Wayne studios, which lie in the shadows of the Purdue Fort Wayne campus. And if you'd like to contact me with an email question that I can answer on the air, you may write me via the internet at mattersofthemind, all one word, at WFWA.org. That's mattersofthemind at WFWA.org. And I'll start tonight's program with a question I recently received. It reads, Dear Dr. Fulver, my father recently moved to a nursing home. How do I get him to be more active there? He has shown little interest in taking part in various activities offered. He has been depressed and remained in his room. Well, you might want to make sure that your father does see his primary care clinician. He may indeed be getting depressed. It's a vicious cycle. When somebody gets clinically depressed, they do withdraw more, they sleep not uncommonly more, they don't eat as well, and in a change of environment, that can be extremely stressful for somebody, and that can contribute to depressive symptoms. So considering that he may have some depression, okay, talk therapy can be useful, but sometimes we'll use medications as a means of helping people have a little bit more neurobiological joy and happiness from that perspective and allow them to get out of that funk. Sometimes when people are going into a nursing home, we have to identify any medical problems they might be encountering. For instance, if your father has undiagnosed sleep apnea, diabetes, low iron, various medical conditions can contribute to him feeling more depressed, but obviously he needs to socialize and find purposeful, meaningful activity the best way possible. It's an adjustment. A stress, by definition, is a change, and an overwhelming stress is where you have difficulty with coping with that change, and he may be enduring that right now. So make sure to contact his primary care clinician to try to see what kind of options could be available at this point. Thanks for your email. Let's go to our first caller. Hello, Shannon. Welcome to Matters of the Mind. Well, Shannon, you want to know, is the need to change clothes constantly between inside and outside where a form of OCD? So in other words, you're going inside the house, you're going outside the house, you're changing clothes upon going outside the inside. Is that a form of OCD? Well, any psychiatrist is going to ask you, why are you doing that? Now, if you're going outside and you're dealing with some livestock and you're getting dirty, sure, it makes sense to change clothes once you get inside. If you're going inside and you take off your shoes, put on slippers for the purpose of not dirtying up the floor, that makes a lot of sense. However, if you know that you're changing clothes inappropriately, that's where it can be considered to be OCD. Now, OCD, obsessive compulsive disorder, is where somebody will have thoughts in the case of changing clothes that you may be contaminated unnecessarily. And when they have those thoughts, you have this loop in the front part of the brain. This is the front part of the brain here. This is the inside of the brain. This loop goes round and round and round. And you can't get that thought off your mind. If you know the thought is illogical and you know that changing the clothes doesn't make sense, you don't need to change clothes, you just took the dog out and came right back in, you felt like you needed to change your clothes, that can be an anxiety condition called OCD. So that's OCD, but on the other hand, we're always going to ask somebody, why are they doing what they're doing? And secondly, do they perceive that that behavior is unnecessary? So if you realize that changing of the clothes and coming back inside is unnecessary, that could be a problem. That's an obsessive compulsive disorder. But merely changing clothes, going from outside to inside, is not considered to be psychopathological for that perspective. Now, a lot of people did develop OCD-like symptoms after the COVID pandemic because they were very fearful of germs. So when they got around other people, they'd want to come back to their home and immediately take a shower and change their clothes because they were fearful of something specifically along the line of COVID. It became, for some people, an almost incapacitating anxiety, but that wouldn't really qualify as OCD yet, but it could get to that point if it got to the point where it was illogical. Shannon, thanks for your call. Let's go to our next caller. Hello, Doug. Welcome to Matters of the Mind. Doug, you want to know if motion sickness is a mental or physical condition. As a psychiatrist, I'm going to hear about motion sickness occasionally, Doug, because motion sickness will have as symptoms nausea, cold chills, maybe a fast heartbeat. And when you have those kind of symptoms, people sometimes wonder, am I having a panic attack? So they get referred to a psychiatrist, such as myself. And I'm finding that when they have those kind of symptoms, they're specifically in a situation such as an automobile, maybe an airplane, even a boat or a train or something where there's motion involved and they have those kind of symptoms. Motion sickness is indeed a physical condition. And as a physical condition, basically, your sensory input is getting overwhelmed in those cases. You've got this central operator in the middle part of your brain called the thalamus. So it's the front part of the brain here, is the middle part of the brain. Thalamus is right there. So the thalamus is the central operator, and if it gets overwhelmed with conflicting sensory input, where things around you, sights, sounds, even feelings for that matter, don't line up, you can get nauseated and you can have a lot of symptoms of a panic attack. But you don't want to be treated for a panic attack, you want to be treated for the underlying motion sickness. So what do you do to avoid motion sickness? Try to get your eyes to focus on one thing off in the horizon and try to reset your thalamus in that way, the sensory input. Secondly, try to avoid alcohol when you're going to be in a situation where you might have motion sickness. Many people know very well not to read when they're in situations such as travel, where they can have more of an inclination to having motion sickness. We hear about all the time when people go on cruises and they're on ships, they can have the motion sickness there. How do you treat it? Ginger is one natural way of treating it, but quite frankly, I think the best way to treat motion sickness is a scopolamine patch behind the ear. Lasts for about 3 days after you use it. Scopolamine is a medical treatment. You'd get that as a prescription from your physician or your nurse practitioner, but that's a medical treatment for motion sickness if you know you're going into a situation where that can occur. Motion sickness is most commonly seen with children and women who are pregnant. But for many people, as they get older, it's not so much of a problem anymore. Don't know why women who are pregnant get more motion sickness. Probably the hormonal dysregulation that occurs during that time. Thanks for your call, Doug. Let's go to our next caller. Hello, Carla. Welcome to Matters of the Mind. Carla, you want to know, is a heartbeat sound or a whooshing in your ears a sign of stress when you're trying to sleep? That's difficult to say, Carla. Sometimes people can have symptoms of what's called tinnitus, where they get ringing in the ears or a whooshing in the ears, sounds in their ears, and that can be an inner ear problem. So with an inner ear problem, that's something that could be evaluated by an ear, nose, and throat doctor. Sometimes the sound of a heartbeat or a whooshing in the ears, especially at nighttime, can be related to higher blood pressure. Okay, so if you're under a lot of stress and you're getting worried about something, if you're prone to having higher blood pressure and a faster heartbeat when you get stressed out about things, sure, that can come across as hearing the heartbeat or having that whooshing sound in your ears like that. So if it's related to stress, sure, that could be related to the whooshing in the ears or the hearing the thumping in the ears, especially at nighttime. But it might be an inner ear problem that could be assessed by an ear, nose, and throat doctor. Carla, thanks for your call. Let's go to our next email question. We have another email question there. And the next email question is, Dear Dr. Farver, how does alcohol use interact with common antidepressant medications? Are there potentially serious consequences for combining the two? The biggest concern we have with alcohol use with any medication will be the potentially fatal interaction between alcohol and benzodiazepines like Xanax, Ativan, Klonopin, Valium. Or we don't use the old phenobarbital type medications, but they can be deadly if you use alcohol in combination with these sedative medications. If you use alcohol with some sleep medications like Ambien, that can be devastating and cause you to be excessively sedated. So the main concern we have about alcohol use will be the sedating effect of it, and the sedating effect amplifying any sedating effect of other medications like the benzodiazepines, the sedatives, the pain medications. You don't want to use alcohol with those kind of medications unless you do so with your clinician's permission on how much you can consume during that time. In terms of direct, what we call pharmacokinetic interaction, no, not a big problem there. It's more of what's called a pharmacodynamic interaction where you have symptoms that are piling on to other symptoms. So it'll cause you more side effects. And when you mentioned antidepressant medications, especially if somebody's in the depths of depression, they're really struggling, I encourage them, don't drink any alcohol until we get you out of this funk and get out of the depression itself, because alcohol is a depressant. It makes you less motivated. It dulls the thinking. Now, some people will say, well, alcohol is the only thing that helps me sleep. It'll help you get to sleep, but it doesn't give you a good quality of sleep. So you don't get a deep sleep, you don't get dream sleep, you don't get all the phases of sleep you need. Alcohol actually suppresses those good phases of sleep. It'll knock you out. As a matter of fact, back in the old days, I remember 30 years ago, they used to prescribe alcohol in nursing homes to help the older adults sleep in nursing homes. That was a terrible idea, but they don't do that anymore. But if you use alcohol as a sleeping medication, it's not a very good sleeping medication. So alcohol is not good for depression, it's not good for sleep. So if you're currently having active problems, it can actually make things a lot worse. And it especially makes panic attacks and anxiety worse. A lot of people will consume alcohol as a means of trying to calm their nerves and help them with anxiety, but alcohol doesn't last very long in the system. When it gets out of the system, you tend to have a rebound effect, and you might even have more anxiety and more panic attacks as it's getting out of the system. Thanks for your call. Let's go to the next caller. Hello, Philip. Welcome to Matters of Mind. Philip, you want to know, are dream disorders an actual thing? Can you have dreams of depression or anxiety? If so, how does this affect you in the morning? Dream disorders, when we talk about dream disorders themselves, we're talking about nightmares. Dreaming is a good thing for the brain. When you dream at nighttime, Philip, what's happening? The thinking part of your brain, the attention part of your brain, it's called the dorsolateral prefrontal cortex. Dorsal meaning it's in the front, lateral meaning it's on the outside, prefrontal cortex meaning it's in this part of the brain here. So that's the dorsolateral prefrontal cortex. This shuts down at nighttime when you dream. And that's a good thing, because when you're thinking and you're concentrating all day long, this area gets really hot. And you're focusing, you're working and working and working. You need to shut it down. So at nighttime, when you shut that logical thinking part of your brain down, anything goes, and you get all these abstract dreams. A lot of them don't make any sense. Some people will say it's a means by which God is talking to them when they are interpreting their dreams. That's a whole other matter. But bottom line is, dreaming is good for the brain. What's not good for the brain, Philip, will be nightmares. Nightmares are coming from a different part of the brain. It's known as the brain stem. You're getting excessive norepinephrine release. And norepinephrine is a chemical cousin to adrenaline, but you're getting all this norepinephrine release excessively, and that's causing nightmares. That could be from past traumatic experiences, but it's not diagnostic. In other words, if somebody has nightmares, we can't say, you've been traumatized, you've had post-traumatic stress disorder because of nightmares. No, it's just a symptom that we have to kind of observe and watch. But nightmares will be a pathological kind of condition that we don't like to see. Night terrors, people often misinterpret those as nightmares. Night terrors are occurring in a whole different phase of sleep compared to nightmares. Nightmares are occurring during the REM sleep, rapid eye movement sleep, the dream sleep, whereas night terrors are where people will maybe sleepwalk. They might just awaken in the middle of the night, be very confused, often yell out. That's why they're called night terrors, but they forget what they're doing momentarily. They forget that they've been sleeping. They're very confused, but they haven't been dreaming. Night terrors occur during the slow wave sleep, so it's a different type of phenomenon. So there are different sleep disorders, but dreaming itself is not something that we would consider to be pathological for people, even if they're having dreams that are very vivid and abstract. Now, you may notice that when you're dreaming, upon awakening, the dreams get erased just like a whiteboard very, very quickly, unless you think about them or write them down. So if you've been dreaming, if you write them down or think about them and try to think about them for a little while, or even talk about what you were dreaming about to somebody else, you'll be able to retain their recollection of those dreams and maybe be able to talk about what they might have meant. Typically, when you're dreaming about things in a very abstract manner, you're dreaming about things that happened to you in the past 72 hours. Especially as the night goes on, you're dreaming about things that happened more recently, maybe in the past 24 hours, right before awakening. So you're symbolically dreaming about stuff, and many people, they'll say, oh yeah, that makes sense, when you tell them, okay, I wonder if anything happened in your life over the past day or two that might have made you think about this or that in the dream itself. But they're not necessarily interpretive of psychiatric disorders themselves, but abstractly, I mean, that's how psychoanalysis often occurs when people are in psychoanalysis, which isn't done so much anymore. I was in psychoanalysis myself when I was going through my psychiatric training, where I laid on the couch twice a week for 2.5 years on a Tuesday and Friday morning, and first thing in the morning is when I did the sessions, so my dreams were fresh on my mind. But in psychoanalysis, they will use dream interpretation as a means of helping you deal with any issues going in your life. And it's interesting, but it's not necessarily diagnostic and not so much used for treatment unless your dreams are very vivid and you're able to really think in an abstract manner and how you would interpret those dreams. Thanks for your call. Let's go to the next caller. Hello, James. Welcome to Matters of the Mind. James, you want to know, what is treatment-resistant depression and what are the benefits of Spravato that's being marketed? James, treatment-resistant depression by definition, and I don't like the definition, but it means you failed on 3 or more antidepressant medications. So if you failed on 3 or more different antidepressant medications, that's considered to be treatment-resistant depression, TRD. I don't like that term, James, because I want to know what antidepressants you've tried and failed upon. In other words, we have 28 oral antidepressants from which to choose. So we have a lot of different antidepressants going back to 1958 when they were first coming out. We have all these different types. For the past 6 decades, we've primarily been using these antidepressant medications that predominantly affect serotonin, norepinephrine, and dopamine. And it's considered to be treatment resistant if you haven't done so well on 2 or 3 of these different antidepressant medications. Norepinephrine, serotonin, and dopamine are getting spewed from the brain stem down here, and they go up to the cortical matter up here. The cortical matter, we call it the gray matter. That's the thinking part of the brain. That's the mood part of the brain. That is regulated by glutamate and GABA. Glutamate is the accelerator, GABA is the brake. So you got glutamate pushing on the accelerator, GABA is on the brake, and that's how the outside part of the brain works. Basically, serotonin, norepinephrine, and dopamine are just getting sprayed out to the gray matter, and they work kind of like in an advisory role, kind of like a passenger in an automobile giving driver advice on whether he or she should push on the accelerator or push on the brake. So the norepinephrine, serotonin, and dopamine consist of less than 1% of all neurotransmission in the brain, and they're serving more of an advisory role. So where does Spravato come in? Spravato will work directly on glutamate. So it's working directly on the accelerator, and it works within a matter of milliseconds. Antidepressant medications that affect serotonin, dopamine, and norepinephrine, to get a meaningful effect, will take off in 4 to 6 weeks. Spravato is a medication. By affecting glutamate, people can see a difference in their mood often within a day. And you might think, James, well, gee, that's a stimulant. That's cocaine. Well, it's different from cocaine. Cocaine is primarily affecting norepinephrine and dopamine very abruptly, and it gives you a pulsatile effect of norepinephrine and dopamine. Not a good long-term effect. It's addicting, and you crash afterwards. Spravato, by affecting glutamate, will make some meaningful changes where you can actually get increasing branching of your little nerve fibers. So with your nerve fibers, there's 100 billion nerve fibers in the brain, and each individual nerve fiber has anywhere between 10,000 to 50,000 little branches. So if you can imagine looking at a bush in your backyard and it's getting all shriveled up, it has fewer branches on it, what do? You hit it with some Miracle-Gro, you give it some more water, you nourish the little bush as a means to get more branching going. So instead of 10,000 branches, it goes up to 30 or 40,000 branches. That's what you're doing when you use Spravato. Spravato is a nasal spray. It's used typically with an antidepressant medication, but as a nasal spray, it's something that within a matter of 24 hours could increase this branching. It does so by affecting this particular natural chemical in your brain called brain-derived neurotrophic factor. We refer to it as natural brain Miracle-Gro. And what it does within a matter of milliseconds after exposure to a medication like Spravato starts increasing the branching. So based on animal studies, and even some human studies are coming out now where they can actually mark in real time the branching occurring in the brain, you're seeing results in a animal and in humans within a matter of 24 hours. You're seeing these physical results of the branching occurring within 24 hours. That's why many people on Spravato will notice that they feel better, and they have an improved mood, more motivation, more happiness within 1 or 2 treatments. Now, we treat people with Spravato twice a week for a month, once a week for a month, and then after 2 months, that can be spread out to every 2 weeks and sometimes less than that, typically with an antidepressant medication. But Spravato has been around since 2019 now, so it's been out for about 5 years. At my clinic, we had completed over 5,000 treatments in the past, and it's a very, very effective treatment. But the reason it's so effective for treatment-resistant depression is because treatment-resistant depression typically involves the antidepressant medications that are affecting serotonin, norepinephrine, and dopamine, and they only do so much. Spravato is affecting a whole different chemical. Thanks for your call. Let's go to our next caller. Hello, Ken. Welcome to Matters of the Mind.
Yes, sir. Thanks for taking my call today.
Hi, Ken.
I have a question. Yeah, this will follow up nicely with your previous caller. I was on a Spravato treatment every 3 weeks for a while, and it became unavailable to me. And then I found another provider here in town that was able to administer the treatments. But unfortunately, I went on Medicare, and now he refuses to maintain those treatments because they don't pay enough. Medicare does not want to reimburse them enough.
Right.
At any rate, what I'm looking for is I wonder what would the next best pharmaceutical that would mimic or most closely resemble that treatment. Otherwise, I need to go to South Bend, or it's tough to find it, and even tougher to find somebody that will treat me on Medicare. So, what would you suggest might be an alternative to that, to esketamine or Spravato?
Yeah, Ken, the challenge with Medicare is that Medicare won't pay currently, and I'm hoping they do in the future, but currently they won't pay for Spravato, the nasal spray itself. Spravato is esketamine. It's the left-sided piece of ketamine. Ketamine was FDA approved in 1970 as an anesthetic, and ketamine has been used IV under the tongue. It's been used in various forms, off-label. In other words, it was never formally approved for depression, but it's been used off-label. It's for depression for the past 20 years. So we've known about ketamine for a long time. It was just never formally approved. So if you get ketamine treatments, you're going to be paying out of pocket. You'll be receiving 2, 4, 6 treatments, whatever might be deemed necessary. But ketamine and Spravato will affect glutamate in a very, very similar manner. So that would be the two medications that would work very similarly. We do have a medication available now as an oral medication, not yet approved by Medicare in a lot of cases, but I think it's time's coming where it might be more accessible. It's called Auvelity. Auvelity is a combination of 2 very old medications. Auvelity consists of dextromethorphan, which is a cough medicine that's been approved for cough for the past 65 years, and bupropion, which is a antidepressant medication, was approved for depression in 1989. So they've been around for a long time. The whole idea of Auvelity is bupropion is there not so much as an antidepressant. Bupropion will increase the blood level of dextromethorphan by over 30 times. And in doing so, high levels of dextromethorphan will affect glutamate in a little bit different way than ketamine or Spravato, and that's why in a different way, being that people aren't as impaired, they don't need to get the treatments under a supervised setting, but they can take Spravato day by day by day, and that will affect glutamate. So Ken, what you're noticing is with Spravato and with ketamine for that matter, you're going to get these effects on that gray matter of the brain affecting glutamate. That's the accelerator of the brain, and it's opposed by GABA. When people have ongoing depression, and they call it treatment-resistant depression because they haven't responded adequately to various traditional antidepressants affecting serotonin, norepinephrine, and dopamine. When they have that kind of depression, they need something different that goes directly to the accelerator, and that would be glutamate. So there's 3 medications available right now that affect glutamate. Spravato is the one that you had tried before. Ketamine's another one, used off-label. You'd pay out of pocket for the purpose of getting ketamine infusions in many cases, but people are using the ketamine in different forms now. And of course, Auvelity is an antidepressant that's an oral version that will affect glutamate in a different way, but keep your ears open for that. Auvelity's been out for 2 years now, and my hope is that Medicare will be covering that as time goes on, but that is also affecting glutamate because of the high levels of dextromethorphan.
Yeah, and I actually miraculously, I was my Medicare plan actually did pay for the Spravato treatments, but they were paying like $900 for a $1,700 treatment. So
Yeah.
that didn't work out so good for my
Hey,
life.
kudos. We treated a lot of patients with Spravato over the years, and we had a hard time with Medicare covering them. It did sometimes, but other times it all comes down to what plan of Medicare you might have.
It took a little work.
I bet it did.
Several phone calls. Okay, well, I appreciate your time this evening.
Hey, good
Happy
talking to you,
Thanksgiving.
Ken. Take care. Let's go to our last email. Our last email reads, Dear Dr. Fulver, can the moon have an effect on my mental health? I always feel like I am more moody when there's a full moon. You talk to psychiatric nurses and OB nurses. They will insist that a full moon will lead to more mental health crises in the case of psychiatric nurses, and the OB nurses will say there's more deliveries when there's a full moon. I've seen different perspectives on that. Now, does something about the full moon make a difference in terms of somebody's mental health? It can be there's more light out at nighttime. So with a full moon, many times people will say they don't sleep as well because it's too bright outside. They need to close their blinds, but they'll say they don't sleep as well. They perceive that they can stay out later when there's a full moon. And obviously lack of sleep or increasing evening activities will give you a diurnal or a circadian rhythm disturbance where you'll have trouble with mental health issues from that perspective. I've actually seen some studies, though, say confirming that there were more mental health admissions during a full moon. So I would not be one who says that's a fallacy. I would say there's a possibility that the full moon might affect people's mental health, but there's always a lot of different theories on why it might do so. Thanks for your email. Unfortunately, I'm out of time for this evening. If you have any questions concerning mental health issues, you may write me via the internet at mattersofthemind@wfwa.org. I'm psychiatrist Jay Favre, and you've been watching Matters of the Mind on PBS Fort Wayne. God willing and PBS willing, I'll be back again next week. Take care. Have a good evening. Good night.
Preceding program on PBS Fort Wayne was made possible in part by
Cameron Psychiatry, providing counseling and care for those that may struggle with emotional and behavioral challenges. More information available at CameronMCH.com.